Okay, so let's start again. So today we are starting from here, which has to do with how to determine or how to use your tape measure to determine the fundal height and how the fundal height is also can be equated or can be used to estimate the week of gestation. Then from there, we'll look at the significance of the key weeks and where to locate what do you call them, the fundus. Okay. And these three are cardinal that when you are learning for the NCLEX, you need to know where to locate the fundus at 16 weeks of gestation, where to locate the fundus between 12 to, sorry, 20 to 22, then at 36 weeks, where the fundus should be located. These are things that they like to ask, so they are cardinal. Okay, that's why I singled them out. Okay, and we look at its relevance as well. So when it comes to fundal height, we know that the fundal height is measured using what we call a tape measure. So you take a tape measure, the normal tape measure we know. So if you have been to the labor ward or the maternity, you notice that they have what you call a tape measure, the ones that our tailors use. It's exactly the same thing. And they are not just using it for using sake. It is helping them to also determine how the fetus is growing. And then out of it, they will know what you call the estimated, week or estimated week of gestation. Okay, so if you come and then they measure, let's say you are asked to come every 4 weeks. And so every 4 weeks up until let's say 32 or 28 weeks. And then you come after 1 month, you go and they measure and there's no much difference. It means it will tell, or there's no difference, to tell them that probably there's something wrong because the fetus isn't growing as expected. Okay. Because as the weeks goes by, the fetus has to grow. And as the fetus grow, the fundal height will also increase. Okay. So it is very important. That is why they have the tape measure there. So fundal height, as we all know, is measured to evaluate the gestational age of the fetus. It helps to approximate. Okay. So during the second and third trimester, that is where we use the fundal height to estimate, or that is where you can actually measure the fundal height using your tape measure. The fundal height, when you measure, okay, when you measure the fundal height, whatever value you get, it is either plus or minus 2 in terms of the week. Okay, so let me explain this. So let's say you have used your tape measure. You measured the fundal height. When you measure the fundal height, you had 28 centimeters. So the 28 centimeters, we are saying that it is either plus or minus 2. The plus or minus 2 means that the fetus could be at the age of 28 weeks, or it could be less than that by 2 weeks. That is, it could be that the actual fetal age is 26 or the actual fetal age is 30. So if it is plus 2, means that the actual figure you have gotten, which was the 28 plus 2, giving you 30, or less than 2. So less than 2, you subtract 2 from the actual figure you had, which was 28 minus 2, you are getting 26. So that is why it is an approximation. It doesn't give you the exact. You can get it to be the exact, but when you are counting or when you are checking, you have to take into account some margin of error that can happen. And so that margin of error, we take it to be either +2 or -2. I hope you are getting it. But in actual sense, when you are recording, after you get, let's say, 28, you just put it at the back of your mind, or you write it as 28 centimeters, which is equivalent to 28 weeks of gestation. But at the end of the day, we all know that it can either be +2 or -2 in terms of the week of what you call gestation. Okay, that is with the fundal height assessment using the tape measure or using a measure to estimate the gestational age. Then when it comes to the areas I said we have to pay much attention to, at 16 weeks of gestation, the NCLEX, they like asking this. I've seen questions on this, a lot of questions, and they will ask you at 16 weeks of gestation, where do you expect to see the fundus? Okay. The reason why they ask that is that they want to see whether you know that at 16 weeks of gestation, you expect to see the fundus at what we call between the symphysis pubis and then that of the umbilicus. And so at 16 weeks of gestation, at least we want to see the fundus. We want to see the fundus between the symphysis pubis and that of the umbilicus. The significance of it is that if someone comes at 16 weeks of gestation and then the fundus is not located between the symphysis pubis and that of the umbilicus, it should tell you that probably the fetus is not growing much as expected. So probably there's fetal growth restriction. Okay. That is one thing you have to also take note of. Another key thing is also that when it is above, let's say, the umbilicus, it should also tell you that probably the fetus is overgrowing. That is why at 16 weeks of gestation, the fundus is above the umbilicus, because at 16 weeks, it should be between the symphysis pubis and that of the umbilicus. That is what you should note. Then at 20 to 22 weeks, where you should find what you call the fundus. So the fundus should be located at the umbilicus between 20 to 22 weeks. And so it is at 20 to 22 weeks, that is where you expect to see the fundus to be at the level of the umbilicus. Okay. And so the same thing, just like the explanation I gave, if after what you call if the fundus is less than or is not at the level of the umbilicus, okay, at 22 weeks or at 20 weeks, you have to note that probably there's also fetal growth restriction or the fetus is not growing as expected. Okay. Then at 36 weeks, the fundus should be at what you call the zyphnoid process. Then from 37 going, it starts to descend back again, because from 37, it has to move up there back into what we call starting to descend into the pelvis for delivery to probably to take over from there. Okay, so these are three cardinal locations that I want everyone here to take note of when you get your question and they are asking you where to locate the fundus. Okay, then when you want to measure the fundal height using your tape, because these are some of the things that can cause you to get either, a false value. That is when you have the bladder being full. When the bladder is full, it kind of pushes, the uterus up. And so at the end of the day, it will cause the what you are going to measure will increase. Okay. And so when you want to measure fundal height, we tell them to empty what you call their bladder or to void before you measure, so that you don't get a false positive what you call answer or a false positive number. Okay, that so ask the client to void before measurement because of the possible uterine displacement from a full bladder. And so this is fundal height assessment, and where you have to spot what you call the fundus at what point or at what age. These are cardinal. These are what the NCLEX will ask you regarding fundal height assessment. If you have any question on fundal height assessment, you can bring it up before we briefly look into this discomfort and how you can manage them during pregnancy. Okay, so let's quickly look into this. These are some discomforts that comes about, and the NCLEX will ask you how to manage a pregnant woman who complains of nausea, vomiting. In terms of dietary management, that is where they like asking, what will be your education for them? So we know that yesterday we established the fact that nausea, vomiting are expected signs. They are the presumptive signs you are going to see when one is pregnant. Okay. And so when someone is pregnant, you expect the person to experience nausea and vomiting. We established that the nausea vomiting is largely due to hormonal changes that takes place during pregnancy. And so it mostly starts, or it's mostly predominant during the first trimester. And usually, I mean, by the end of the third trimester, the nausea and vomiting will subside, even though some people still continue to have it. That is where you have it becomes abnormal. And so we'll talk about hyperemesis gravidarum in our next probably slides, okay? But what we are talking about now is the normal nausea and vomiting that a pregnant woman will experience. So we know that the cause of it is because of the hormonal changes, largely due to elevated HCG level and then other hormones, as well as, I mean, carbohydrate metabolism changes that takes place during pregnancy. And so these are what causes the nausea, vomiting in pregnancy. Our main interest here is for us to understand how to handle such clients or how we're going to educate them. And so the first one is about diet. So if you have gotten questions on this from your Q bank, you will see that in the options you get encourage the mother to take crackers, dry crackers. Okay. So things that will not stimulate nausea and vomiting is what we encourage them to do. Another thing we always tell you will see it is advise the mother to avoid brushing their teeth first thing they wake up. So we all know that the moment you wake up, normally the first thing you want to do is to go and then brush your teeth. Okay. But if you are pregnant and you are experiencing this nausea and vomiting, what you want to do to avoid the nausea and vomiting is to wait. Okay, when it comes to brushing your teeth. So we tell them to avoid brushing the teeth immediately after they wake up, okay, or immediately after they rise. But the moment you rise up, if you go brush your teeth the first thing, it can, stimulate nausea and vomiting. So we encourage them to avoid brushing their teeth immediately after rising. So you have to wait for some time. Even it says that they have to take the dry crackers even before they brush their teeth. So we tell them not to brush their teeth the first thing they wake up. Then eating small, frequent, low-fat meals during the day. We all know that when your abdomen becomes full, it can also stimulate the nausea and vomiting. And so what we do is that we encourage small, frequent meal. And so that means that when you eat, you don't have to eat at a goal for your abdomen to become too full to the extent that you can't control yourself, which could lead to the nausea and vomiting. So we tell the mothers to do what? To eat small, frequent, low-fat meals, okay, during the day. And then they have to also drink between meals rather than at meal time. This is also one of the things that you see, one of the options. And so we say they should eat or they should drink between meals. And so between meals means that when you are eating, don't drink the water alongside your meal. After eating, you wait for some time before you drink the water. It also helps not to cause the abdomen to become too full at a go, which can also stimulate the nausea and vomiting. We say they should avoid fried foods and then spicy foods. They should eat a protein snack at bedtime. So when they are going to sleep, it's advisable they eat what they call protein snacks. And then they also have to suck on hard candies to prevent dry mouth as well. Then we have to make sure that if they want to use any other thing, okay, probably they want to use some preparations or some herbal preparations or other methods to help control the nausea and vomiting, you need to tell them to report to the healthcare provider on whatever they want to take. And so if they want to, rely on other alternatives to control their nausea and vomiting, they will need to, ask the healthcare provider on that before. Then taking antiemetics. When it comes to the antiemetics, when it comes to the NCLEX, one of the common one you see in your exam is ondansetron. I always make mention of ondansetron. And so down here, you see more of metoclopramide and all that. But for the purpose of the NCLEX, one of the medication that when it comes to control of nausea and vomiting, that is safe to be used is ondansetron. So you can put that in your packet as part of today's class that when it comes to nausea and vomiting, one of the preferred medication, especially during pregnancy, is ondansetron. You will see that more common in your questions as well. And so that is on controlling nausea, vomiting that is experienced during pregnancy and how we educate our clients on it. If you have any question you want to ask on what I have said, you can bring it up before I talk about um, how to also educate clients on how to avoid experiencing dizziness that can lead to syncope and all that, especially when it comes to client's position. It's very, very important. So the next thing we talk about is the syncope, okay, which usually occur during the first trimester as a result of, I mean, the pressure, especially in the third trimester. So supine hypotension occurs particularly in the second and third trimester, even though in the first trimester, you can also experience the dizziness. Mostly the first trimester on is because of what you call hemodilution, okay, an anemia that mostly occurs is during pregnancy. And so the woman tends to experience dizziness and then they can even fall down. But for the second and third trimester, it's mostly due to the weight of what you call the uterus that is exerted on the inferior vena cava that displaces the inferior vena cava and then can lead to a drop in what we call cardiac output, and at the end of the day, the person will feel dizziness and then can fall down, especially when the person changes position abruptly. Okay, so majorly as a result of one hormonal changes that will cause increased blood volume. Okay, and then the anemia, fatigue, sudden position change, and then lying on your back supine. And so that is why when you are pregnant, it's not advisable for the individual to lie on the back to prevent what you call supine hypotension. Okay. When it comes to the dizziness and all that happens in pregnancy, how do we manage it? And so we tell them that when they sit, they have to elevate what you call the feet. So when you elevate the feet, it helps with what we call it helps to send the blood back. Okay. I mean to return what we call blood back to the heart for it to be circulated. Okay. And so they should elevate the legs when they are sitting. Then rest for 4. That is when they lie down, they should avoid change of position quickly. And so teach the client to change position slowly. So when, let's say, the person is asleep and the person wants to wake up, the person has to do that gradually to prevent, a sharp drop in the blood pressure that can lead to dizziness and the person will fall. Then the nurse needs to instruct the pregnant individual to avoid lying in a supine position, particularly in the second and third trimester. The supine position, places the individual at risk of supine hypotension, which occurs as a result of the pressure of the uterus being exerted on what you call the inferior vena cava, as I already explained, which can drop what we call the cardiac output at the end of the day, and the person can experience dizziness and fall down. So this is how to tell the mothers, okay, to also avoid dizziness along during pregnancy. These are all NCLEX interests. That is why I've taken my time to go through, and they are very easy. But when you get them, how to educate them, the question will always be what would be the most appropriate response, or what would be the most appropriate education for your mother or for the pregnant woman. Okay. Then when it comes to urinary frequency, we are looking at what happens when the woman complains of urinary frequency and which of the trimesters that urinary frequency is expected. Let me say that urinary frequency is expected during the first and third trimester. Yesterday, I made mention of this. The second trimester, typically, the woman wouldn't experience what you call the urinary frequency that much. Urinary frequency is not typical of second trimester. So when you are reading your question, your case study, and someone is pregnant, assessment findings, everything tells you that it's a pregnancy related question of putting, and then the person complains of urinary frequency during the second trimester, and probably maybe they are asking you to highlight which assessments will require a follow-up, and then you have the person is in the second trimester and it says that the person is having urinary frequency and some form of pain during urination. The moment you see this, it should click in your mind that the person is having UTI. And you know, UTI in pregnancy is very bad. It can lead to a lot of complications. And so when you see urinary frequency in second trimester, it is not typically normal. Okay, it requires you to highlight for further what you call management. Okay, so urinary frequency is only expected in the first and then the third trimester. First trimester, because of hormonal imbalances, hormonal changes, so the person will feel the urge to empty the bladder more frequently. And the third trimester, because of the weight of what you call the uterus exerted on the bladder, so the mother will feel the urge want to empty the bladder faster. Okay, but like I said, typically second trimester urinary frequency isn't expected. So when you see it in your question, your case studies, you have to highlight as something that you need to be followed up. Okay, urinary frequency typically we manage with, some, you don't actually need medication for this. You have to tell clients amount of fluids they will have to take. Okay, and so they should drink not less than 2 liters. Okay, because they are urinating more, they are losing more fluid, so they need to replace the fluid. And so at least between 2 to 3 liters if the individual doesn't have any underlying condition. That is the most advisable amount of fluid that they will need to take. At least it should not go below 2 liters. That is 2,000 per day. And then they should limit taking the fluids at night. When when you drink a lot of fluid at night, what happens? You are likely going to wake up at night to empty your bladder, and that could also affect your sleeping pattern. So that is why he says that they should limit fluid intake in the evening so that it will kind of limit or prevent what we call sleep disturbance at night, and then limit intake of natural diuretics. The natural diuretics are caffeine, tea, watermelon, and then lemon. If you have taken watermelon before, this is why you take too much. You know what happens? Because it already contains a lot of fluid. And so typically you're going to also produce a lot of fluid when you take it. Okay. So and then coffee, lemon, they can all cause the individual to what you call produce a lot of urine. And so when someone is pregnant and you want to limit the frequency at which the individual will be urinating, these are some of the natural fluids that the person would have to avoid. Then avoiding at regular intervals. And so one of the things are that we encourage them to void at regular interval, at least every two hours. They will need to train their bladder so that every 2 hours they are probably going to empty the bladder. Okay. And so voiding at regular intervals, and then sleeping sideline at night. They will need to wear perineal pad, okay, so that at least it will absorb what you call the urine or the urine after they have urinated, to prevent irritations and all that if they go where something that is not cutting enough. Okay. And then performing Kegel. I wish our midwives are here to tell us how the Kegel exercise is done. I always get people to take us through how Kegel, but the Kegel exercise, it helps to kind of strengthen what we call the pelvic floor, okay, so that it holds the bladder in place, okay, to prevent the frequency at which or the sensation or the frequency at which the person will be urinating. Okay. And so we encourages them to engage in what we call Kegel exercise. Let's go and look at how Kegel exercise is done. Our midwives, if you're a midwife here and you want to take us through, I learned it's one of the exercise that you regularly engages your clients in. And so Kegel exercise will also help strengthen the pelvic floor. Okay, so it can support the bladder as well. This you notice that these are all things that revolves around client education and how clients will manage this kind of issues when they are reporting it to you. When it comes to the discomforts, breast tenderness will be the last thing here. And so when it comes to breast tenderness, my interest is on how the client should handle the breast when they start to experience what we call the tenderness, and then the small discomforts that comes about with it. And so breast tenderness occurs from first trimester throughout the pregnancy. And then this is caused mostly by hormonal changes, estrogen and progesterone level that increases, making preparation for breast milk production. And so that is what causes the discomfort or the tenderness. When it happens, they will need to wear supportive bra. Then when it comes to breast cleaning, okay, I've seen questions on this, how the mother should clean the breast. Okay, they shouldn't use, if you see any question which says that encourage the person to use soap, no matter how they describe the soap, whether it is mild soap or whether it is hard soap or it is medium soap they are describing, don't go for it. It is a trap. Okay, so we don't use soap on the breast, because when you use soap on the breast, when it dries up, it can cause some form of cracks on what they call the nipple and then the areola area. And at the end of the day, it becomes a medium for invasion of what you call bacteria, which can lead to infection. And so if when it has to do with cleaning the breast, we always encourage them to wash the breast with lukewarm water. Just the water is enough, and they dry it up. So avoid use of soap on the nipples in the area to prevent drying of the skin. No matter how they describe it for you, that encourage the mother to use soap on the breast. Never go for such options. It is always a trap for you. And so that brings us to an end on how to handle the breast when it comes to, or how to handle those discomforts during pregnancy, which are all normal. Okay. Any question on whatever I have said so far before I go into this? I know what I'm coming to do now will generate where the questions will come from. Okay. Any question, any input, any clarification, any addition here? Okay. So let's talk about the various regular um, antenatal, antepartum diagnostic testing that are compulsory. So these are things that in the States, they are compulsory for you to do it. So the moment you are pregnant, we take you through all this, okay, to find out whether there is any abnormality, there is any issue that needs to be identified as early as possible to prevent complication in the future. Okay, so now let's go into them. So first one we'll be looking at has to do with how often the individual has to visit the healthcare provider or has to go for his or her antepartum visit. Okay, I say his or her. So how frequent the individual will have to visit um for her clinic follow-ups. So we know that from the first trimester, from the time that you start up to 20 to 32 weeks of gestation, you have to go every 4 weeks. Okay. And so let's say that your first visit was at 12 week of gestation, or you started antenatal at 12 week of gestation, and you want to know when you go for your next visit, or in your question, it says that a mother comes for her first antenatal visit at 12 week of gestation, and the mother asks you, what will be her next date of visit, or when should she come back again for her next assessment or for her next visit? How are you going to answer this? And so what we need to understand is that when it comes to the schedule you have to follow, okay, from the first trimester up to 28 to 32 weeks, the person has to come every 4 weeks. So if the first visit was on the 12th week, and we are saying that from that up to 32 or 28, depending, the person has to come every 4 weeks. So you add 4 to 12, 4 plus 12, you are getting 16. So it means that this person has to come back at 16 weeks of gestation for her next visit. Then from 16 plus 4, we are getting 20. Then 20 plus 4, we are getting 24. Then 24 plus 4, we are getting 28. If the woman gets to 28 and everything is normal, they haven't spotted any abnormality, the person will be scheduled to come for an additional 4 weeks up to 32. And so from 32 weeks up to 36, the person will be coming every 2 weeks. Okay. Then from 37 going, or from 36 to 40. Okay, after 36 weeks, you are entering into 37. And so from 36 up to 40 weeks, you'll be scheduled to come every week. up until you deliver. Okay. So this is the schedule that everyone here will need to know. When you get your question and then you are asked, a woman who comes at 16 weeks of gestation asks you when will be her next visit, and you are sitting down, you don't know what to say, or you are confused. You just know that if the person is at 16 weeks, the next visit will be in 4 weeks' time. So you add 4 weeks to the 16. Then up to 32, 28 to 32 weeks, the person will be coming. After that, the person will be coming every 2 weeks. And then from 36 to 40 is every week up to the time the person will deliver. Okay. So the usual schedule for antepartum head care visit is every 4 weeks from the first 28 to 32 weeks. And then every 2 weeks from 32 to 36 weeks. And then every week from 36 to 40 weeks. This is what everyone needs to know if you are. Is there any question on what I just said? If you have any question, you can bring it up. Before we go into the next thing, which has to do with resource factor assessment and its relevance, and then what we do. Okay, so let's go into it. I know here it will generate questions. Okay, so when it comes to resource factor assessment, we all know that we all have our blood types, right? And so we have
But Samingo, sorry to cut you short. I wanted to clarify something. You see, when you were explaining the weeks for checkup,
mhm.
are you what I'm saying here, is it that when the person first visit is at 4 weeks, or they come every 4 weeks till 36 weeks?
So this has to do when the person has started her antepartum um visits. Okay,
Mm-hmm.
typically, I mean, the healthcare provider will start or will ask the person to start her regular visits from 12 weeks going. That is the standard. Even though some people can start as early as 10 weeks or 8 weeks, some people can start. Okay. So let's assume the person started her visits at 8 weeks of gestation. And we are saying that from the first week up to 28 to 32 weeks, between that duration, whichever week the person started her antenatal visit, the person will be going every 4 weeks or every four
Oh,
weeks up to the 28 to 32. Then from there, the person will move to 2 weeks up to 36. Then from 36 up to 40, it will be, every week.
okay. All right.
Okay. So let's look at what I was coming to start, which has to do with resource factor typing. And so resource factor typing, when it comes to the NCLEX, is one of the things that we need to understand, okay, and what we do for the mother, okay. And so ideally, like I said, these are regular things that has to be done for every pregnant woman. We need to determine your resource factor, okay. And so we need to first of all determine your blood to know which of the groups you belong to. And so we all know we have A, B, we have B, we have O, right? Then we have what you call the antigens. Okay, so the antigens, if you have the antigens, we say you are either A positive, B positive, whatever positive. Okay. Then if you don't have the antigen, then we say that you are negative. Okay. And what makes it important is the fact that if you don't have the antigen, you cannot receive any blood at all. Or when there is any issue and then there is a missing up of a blood with a different, let's say there's your blood mixed with a different blood with an antigen, your body will see that as what you call an external factor within the body, and the body will start producing what we call antibodies against it. And that could lead to a whole lot of complications. And so that is why when one is pregnant, we have to do the blood groupings. And then after doing the blood grouping, we have to identify whether the person has the antigen or not. And so we term that as rhesus positive and rhesus negative. And so if you have a rhesus when you are pregnant and you visit your first visit or whatever within the first trimester before 28 weeks, usually the first time you go, they'll have to do all the labs. And so they will do your blood group, and then after the blood group, they will determine whether you have the rhesus or you have the antigen or not. And so if you have the antigen, your blood group will be determined as something positive, rhesus positive, right? Then if you don't have, it will be indicated as negative. When your rhesus comes out to be positive, fine, there's no cause for concern. The reason why there's no cause for concern is that a rhesus positive blood can receive from either a rhesus negative or a rhesus positive. So if you have a rhesus positive, there's no cause for concern. Okay, in quotes, there's no cause for concern because a rhesus positive should be able to receive blood from a rhesus negative and a rhesus positive without concern. But then if your rhesus status is negative, then it raises an alarm because you can only receive blood from someone with what we call a rhesus negative. Or when your blood mixes with someone with rhesus negative, there wouldn't be any problem. But if your blood goes to mix with someone with a rhesus positive, there is a cause for concern because the body will see the rhesus positive as a foreign body, and the body will then start producing antibodies against that. Let's bring it to childbirth. Now, we know that, two people had to do their own things, and then you got pregnant. And so the mother will have a certain blood type, and the father will have a certain blood type. Ideally, when you are doing this, you need to know the status of the father so that when you do the test on the mother and then the test comes out to be negative, based on the father's blood type, will tell the healthcare provider what to do. Okay, but sometimes you don't know the status of what you call the father because the father will, and mostly the child picks what you call the rhesus status of the father. And so let's say the mother blood is tested and the mother is negative. Okay. And then we know the father status to be also negative. There's no cause for concern because at the end of the day, the child is going to pick one of them. And then mostly is the father's blood type that the child mostly picks. And so if the child picks the father's type, which is negative, and the mother is also known to be negative, at the end of the day, during childbirth, or if anything happens during pregnancy, and then there is maternal and fetal blood messing up, there wouldn't be any problem. But then if the father is known to be positive, listen to me. If the father is known to be positive, and then the mother blood is tested, and then the mother's status is negative, then there is a cause for concern because the probability that the child will pick the father's, blood status is very high. Okay. And so at the end of the day, if there is any problem and there is a missing of maternal and then the fetal blood, the body will see what we call the body will see that of the positive coming from the child as what you call external bodies, and then they will start producing antibodies against it, and that could lead to complication developing, can lead to anemia and all that. And so when one is pregnant, we do this so that we identify what you call the mother. What is the status of the mother? And so I said that if the mother is negative, there is a cause for concern. Why is it a cause for concern? It's a cause for concern because if during childbirth, definitely there's going to be missing of what you call maternal and then fetal blood. I mean, definitely because they are going to cut the placenta, or the placenta is going to separate. So during that process, the mother and then that of the child blood is going to miss. And so when that missing happens, the body will see that as what you call foreign body. That is the mother's blood will see the child's blood as what we call foreign body. And then the body will produce antibodies. Okay. But mostly for first pregnancy, it doesn't cause problem because should in case nothing happened to the mother during pregnancy, there was no injury and then there was no abortion or anything, and the pregnancy was successful. It is only during childbirth that is where you see the mother and then the fetus blood missing, likely missing. And so when the antibodies are generated, it is unlikely to affect the baby. But then subsequently, the subsequent pregnancies, and so after the first pregnancy, mostly the first pregnancy, the baby is spared because if nothing happens, there will not be any blood messing up unless during birth. And during birth, you can take your baby for free and nothing will happen. Unless there was abortion or there was something that caused the blood to miss, or there was some form of injury, abdominal injury, and then there was a missing of the mother and that of the child blood. During that time, you could have the antibodies produced. And then when the antibodies are produced, they can attack the baby while the baby is in utero. Okay, and that could lead to anemia and then other heart-related complications. Okay, but then if nothing happened at all, the baby will go free. But the subsequent pregnancies, that is after the first one, the second one, again, it's the same father. And so definitely, if the father is positive, the child is likely going to be also positive. And so the second pregnancy, the mother's body has already produced the antibody. So when the next pregnancy comes, the body will see that child or that fetus as a foreign body, and then it will start attacking what we call the fetus, and that can lead to anemia. It can lead to heart failure. It can lead to jaundice and a whole lot of complications. Okay, and so we need to understand what we call razors, and it's important. And so what the NCLEX will ask us is that during pregnancy, when you test the mother and the mother is negative, what do? You have to wait again at 28 weeks of gestation. You do the test again. If the test comes out as negative again, we give something we call ROGAM. We give ROGAM. The reason why we are giving the ROGAM is to stop the mother's body from producing what we call the antibodies. So we give ROGAM to the mother at 28 weeks of what we call gestation, when the mother's rhesus factor is known to be negative. And then again, when the child is then born, and then the test is done on the child. And then, ideally, you should be able to test the child to know the status, whether the child picked the mother or he picked the father's status. Okay, but it's a very, it's very difficult to be done. So we wait until the child is born. When the child is born, we then test the child to see the status of the child. If the child is born and the child comes out to have a positive blood type, and then the mother is negative, within 72 hours, we need to give ROGAM again, okay? Or ROGAM has to be administered, okay? So Rhesus typing is done to determine the woman's blood type in Rhesus antigen system. Rhesus positive indicates the presence of antigen, and then a Rhesus negative indicates absence. If the client's Rhesus is negative, if the Rhesus is negative and has a negative antibody screen, the client will need a repeat antibody screen and then should receive ROGAM at 28 weeks of gestation. This is what I want everybody. All that I spoke, I just wanted you to understand the physiology behind all that I said. But the important thing about what the NCLEX will seek from you is what I'm talking about now. That at 20, at the first visit, the test was done. The mother status is known to be negative. Let's say we know the father to be positive. And so at the end of the day, we says that if the father is positive, the likelihood that the baby will pick the father's status is very high. It's about 90%, 99% high. And so we don't want any situation where if there is any instance where there is a missing of maternal and then fetal blood, there's going to be complication. So we wait up until 28 weeks, then we do the test again. If the test comes out to be positive, or the test comes out again that or confirms that the mother's status is negative at 28 weeks, we give what you call the an anti-D, or that is Rogam. We give Rogam to the mother to protect the mother or to make the mother's body not to produce the antibodies. I hope you are getting me. Then during childbirth or when the client will also require Rogam within 72 hours after delivery if the infant's resource is confirmed to be positive. So when the child is born, we then test the child to be sure what status the child came with. So if the child came with a status of what you call positive, then the mother will need to receive another dose again, or the mother will need to receive Rogam again within 72 hours. Remember the time duration, within 72 hours. And also, during pregnancy, if the mother had any form of complication, like there was abruptio placenta, we know during abruptio, there's premature separation of what we call the placenta. And so because of the premature separation, the mother is going to bleed. And so during that bleeding process, there is a likelihood of one missing of maternal and then that of the fetal blood. And so because of that complication, you might need to consider giving Rogam to the mother if the mother had a negative blood type. Then, if there was any form of, let's say, injury to the mother, let's say the mother had an RTA, and then the RTA, there was an abdominal injury along the line, and the mother was seen bleeding per PV, there's likelihood that, something had happened to what you call the fetus, and so there's what you call probability that the fetal blood and the maternal blood will mix. So you need to give Rogam in that instant again. Then, let's say there was a miscarriage or abortion, and the mother status is negative. We don't know the status of the fetus that was coming, and so as a form of a prophylaxis, we also give Rogam if miscarriage or abortion happens and then the mother blood status was negative. Also, let's say they do amniocentesis. Amniocentesis is one of the procedures that are done to obtain amniotic fluid to assess for any form of congenital abnormalities. Okay, and so during amniocentesis, injury can also happen, and then maternal and fetal blood can also what we call miss out. And so if let's say after amniocentesis and then there is a missing of maternal and child fetal blood, there will be a need for Rogam to be given if the mother has what we call a resource status to be negative. These are what I want everybody to understand when it comes to the NCLEX. I've seen that some people have kept some things in the chat box. Let me see what. So it says that, can you take that again? Part of the chat, please.
No, sir, please, sorry to interrupt. You've already explained it. I didn't get some parts, but you already explained. But
So
the
it's
reason why I asked, yes, it's fine. The reason why I asked of the child is
mhm.
most of the times they bring babies to my unit and then we give them this immunoglobulins.
Mhm.
So, but
At,
when we were talking,
at,
I didn't hear you mention that when the mother's resource is negative and probably the child takes after the father, which is probably a positive this thing, we give the mother rogam again. What of the child?
you're asking what of the child?
Yes. Do we, or it's just the mother that we give the rogam to?
Ideally, it's the mother who received the rogam.
Or she has the negative resource?
Yes,
Okay.
not the baby. And so,
Yes.
like you remember, I told you that for a positive blood can receive from negative, and there wouldn't be any problem.
Yeah.
So if the baby is positive, and then the mother's blood even enters the baby's blood, nothing will happen to the baby.
Yes, please.
I hope you are getting me.
Yes, please.
But it is the mother own that will produce the antibodies and start attacking the baby.
Yes, please.
I hope you get the point.
Yes, sir.
Uh-huh.
Thank you.
Yeah.
Okay.
Ophelia.
Basaki. Sorry, Bros Amingo.
Yes, Madam Sally.
Yeah, what about if the father is positive and the mother is positive?
No problem. Free to go. They
Even
wouldn't.
negative, free to go.
Yeah, free to go. Negative, free to go. The
Okay.
reason why negative, free to go is at the end of the day, the baby will pick one of them. And so if the mother is negative and the father is negative, and we are saying that the possibility of the baby picking the father is very high, the baby will come out to be negative. So negative, no problem.
Okay.
So mostly
Hello.
it is when you don't know the status of the father. But if you know the status of the father and then the mother is tested, then you can then conclude. But sometimes we do it blindly because we don't know the status of the father and we don't want to take risk. And so if the mother is negative, I mean, some healthcare providers will go ahead to ask the mother to take the ROGAM because they don't know the father's status. But if the father's status is known, let's say the father is negative, mother is negative, no need to give ROGAM.
Hello,
I hope it's clear.
hello, boss. Okay.
Yes, Madam Ophelia, you can come in.
Yeah, please. To the lady who was asking of the immunoglobulin is given to babies who have whose their mothers have the hepatitis B
Yeah, I
usually.
figured. I just remembered I was mixing things up.
Okay,
Okay,
okay.
Thank you
so
very much.
that is for her being.
Yeah.
Yes.
It was after
Okay.
you answered and I was thinking about I'm like, nah, Mrs. Then I make it came.
Don't worry. All right,
So,
thank you.
Amingo,
Yes.
so what you are saying is if the mother is negative, the baby is positive, and then you don't know the status of the father, that's when you go ahead to
No.
give the program.
So we say that you can only determine the status of the baby when the baby is born. Even though you can determine the status of the baby whilst the baby is in utero through amniocentesis and other advanced procedures, but because of the risks associated with that, healthcare providers don't do it. Okay, so they wait for the child to be born before they test the child to know the child's status. But what I'm saying is that if you test the mother and the mother is negative, the mother's resource status is negative, and you are able to establish the father's status, and the father's status is also negative, we don't give ROGAM because father is negative, mother is negative. Baby is going to pick from one of them. And I've said that the likelihood that the baby picks from the father is very, very high. And so at the end of the day, the baby will pick the negative blood type. And so the baby and the mother all will have the same resource factor, which is negative. And so no issue, you don't give ROGAM. But then if the father is known to be positive, the father's resource status is known to be positive, and that of the mother is tested and then the mother is negative, that is where there's a cause for concern because you don't know what the baby is coming with. But we've already established that babies usually pick father status. And so we assume that the baby is coming with a positive status. And so we go ahead to give our ROGAM at 28 weeks of gestation. Then we wait again till the mother delivers. When the mother delivers, we then test what we call the baby again to then establish whether the baby came with the father status or pick the mother. And so if the baby came with a positive blood within 72 or a positive result status within 72 hours, the mother will need to take a repeated dose of what we call a ROGAM. Okay. And then I gave the other instances when there is RTA, and then there is abdominal injury and all those things. And I mean, there is likelihood of what we call bleeding that could lead to missing of maternal and fetal blood. Okay. I also
Okay.
said that sometimes you don't know the father's status. Sometimes you don't know the father's status, but the mother is tested and the mother comes out to be negative. We take the risk to go ahead and give what you call the woman the ROGAM, regardless of we knowing the father's status, because we don't want to take risks. Let's say the person comes and then we don't want to give the father out for various reasons, okay? And so for that instant, you go ahead to give your ROGAM, even though you don't know the father's status, but the mother has come out to be negative. I hope you are getting me.
Yes, sir. I get you. Thank you.
Okay. Any other question? Any other question here? All right. So
Boss Amingo,
yes.
please, did you say when both parents are negative RH, we don't give the ROGAM? What about the subsequent pregnancies? What if it's not the same husband or boyfriend, and then what will happen?
So the subsequent pregnancy. So so we are giving it for the current pregnancy. We are talking about the current pregnancy, okay? And that is if the father is known, okay? So with remember that if the mother is what do you call negative, father is negative. I've said that baby is likely going to pick one of them and which is going to be negative. So there wouldn't be any antibody production. The antibody production only comes about if the mother is negative and the father is what you call positive. That is where the antibody production happens for the subsequent pregnancy. But if they are all negative, there wouldn't be any production of what we call antibodies to attack the subsequent pregnancy. So it is the subsequent pregnancy that you need to identify the status of the father again. I hope you are getting the point.
Okay. So even if it's not the same father, you still need to. I'm not getting it well.
No, I want you to get it. What I'm saying is that, so let's say that the mother first pregnancy, the father was known to be negative, mother was negative. No ROGAM will be given because at the end of the day, the child will come out with negative. So the body wouldn't see it as, the mother's body wouldn't see the child's own as, a foreign body to attack it. And so it wouldn't produce any antibody to it. I hope you are
Okay.
getting
Yes.
Then
Thank
the
you.
subsequent pregnancy, let's say the second one was with a different father, which that different father is now positive. And so for that second pregnancy, the mother will need to take the ROGAM because the father, the expected father is having a positive blood, and then the mother is negative. So the woman would then need what you call ROGAM for the second pregnancy. If that was for a second person and not the same father. I hope you are getting
Okay. Thank you.
Sir, please, and how many times can a rhesus negative mother receive ROGAM?
It's given for every pregnancy.
Okay. I'm asking because of the other instances that you taught or you were teaching us. The
Yeah.
the mother's blood and the fetus blood mixing when maybe in a RTA and then the amniocentesis, all those things. So to me, I was thinking, let's say after 28 weeks or at 28 weeks, when the lab is done and then they see that the mother is rhesus negative, they give the Rogam. And then maybe along the line, she gets involved in an accident and then we suspect the blood mixing. You have to give another Rogam. And then when she gives birth to, that's what I was like.
Yeah. So Rogam is given for every pregnancy.
Okay.
If let's say with the same father, let's say it's the same father or the same man, and that man is positive and the woman is negative, for every pregnant that they will have, the woman will need Rogam. So it's not easy. And in Ghana, I learned it's very expensive, eh? Someone told me her experience that she's a known resource negative and she bought one and the nurses mishandled the medication and the medication fell down. And something that cost over 1,000. I don't know whether it's still around 1,000, but I know it was around 1,000 some time ago, between 800 and 1,000. And she had to foot the money again to buy another one again. So it's not easy, it's expensive. I don't know whether in the US too it is also expensive like that. Any other question on this before we move?
Sorry, Sir Amingo.
Madam.
So what if the mother is positive and then the father is negative?
Yes, so if the mother is positive and the father is negative, there is no cause for concern.
Okay.
Do you know why I said there's no cause for concern? Because I already told you that for a positive blood type, you can receive from negative or positive without any problem. Okay, so if the father is known to be negative and then the mother is positive, because we are saying that if you have a rhesus positive blood, you can receive blood from a rhesus negative and a rhesus positive without any problem. And so during childbirth, if let's say mother and then the baby blood messes up, the body wouldn't see, because at the end of the day, the baby is negative. The baby doesn't have the antibody, so nothing will be produced. No, sorry, it doesn't have the antigens, so nothing will be produced against it. So the baby is coming with negative, mother is positive, no problem. You wouldn't give any Rogam. So it is only when the mother is negative that is where it is a cause for concern. Do you guys understand the point I'm making?
Yes, please.
Please, I have a
Yes,
question.
please.
So let's take notes when we get the questions so that we analyze what they are asking. Yes, I heard a voice. Someone says she has a question.
Yes, I have a question.
Yes, Madam Vivian.
So, if I heard you right, you said if the mother is negative and the father is negative, automatically the child is going to be negative, right? Is that what you're saying?
So automatically, yes, the child will come with negative. If only the child is truly the father's.
Okay.
If truly the child is for the father, it automatically be negative.
Okay, thank you.
Yeah. I think someone says I think it's imperative that the fathers are tested right. Yes, so ideally, yes, the fathers needs to be tested so we establish what the fathers have. Yes, that should be the ideal thing. But and sometimes we don't want to give the fathers out, so we want to hide things. So at the end of the day, we take everything and so that is. But if only the father is known and you are going to do it, the giving or the taking of Rogam depends on the father's status. If only you're 100% sure that that child coming is for that man, then that is good to go. Okay. Is there any other question on this before we move? Okay. So let's make progress. Let's do rubella titer. And so this is very simple when it Yes, I'm hearing some voice. Are you asking a question? I always prefer you raise your hand so I can call you. All right, so let's look at rubella. So with rubella, we know that this is a virus that if you are pregnant and then you contract this viral infection, the baby will be affected because this virus can cross what you call the placenta barrier and then really cause some form of congenital abnormality during pregnancy. And so as part of what you call the routine um uh, what you call labs, okay, in the States, every mother is tested for rubella, or we do the rubella titer status to know what status you are coming with or you have, whether you are immune or you are not immunized. Okay, so if the client has a negative titer means that the person is not immunized against what we call the rubella virus, and the person stands a chance of contracting the viral infection. Okay, and so we mostly represent that by a value of it's written as less than 1:8. So when you see a rubella titer status indicated as less than 1:8, it means that the woman is not immunized and the person is susceptible. Okay, and so what it means is that the person will have to receive the appropriate immunization. But this is where the NCLEX will ask, how do we give it, or when should this vaccine be given if the mother's status is known to be negative? That is where they like asking, because this vaccine is a life attenuated or vaccine, and we know that when you are pregnant, we don't receive or you don't take life attenuated vaccine. And so the life attenuated vaccine, I hope you know, measles, so MMR, right? Measles, mumps, and rubella. These are all life attenuated vaccines that when you are pregnant, we don't receive these vaccines. Okay. And so because of the pregnancy, we wouldn't give what you call the vaccine if the rubella titer status is negative or is less than 1:8. We will wait for the mother to deliver, and then after the delivery, then the mother will be given what we call the vaccine. And then when you take the vaccine, you have to do everything possible to avoid pregnancy for at least 3 months. Okay, and so after taking rubella vaccine, you are asked to avoid pregnancy for at least a period of 3 months after taking the vaccine. So clients must use effective birth control after taking what we call rubella vaccine. Okay, at the time of immunization, and must be cancelled not to become pregnant for 1 to 3 months after the immunization, and then to avoid contact with people with suppressed immunity and all that. Then, if the rubella vaccine is also administered at the same time as that of ROGAM, it may be inactive. Okay, so we don't give ROGAM and rubella at the same time. We know that ROGAM has a specific time duration that it needs to be given. We said ROGAM should be given within 72 hours. If after delivery the baby is positive and the mother is negative, I hope you remember. So we said that is when you give ROGAM. And so make sure that you are not giving ROGAM and then rubella at the same time. If a woman needs to receive the two, you will have to give ROGAM first, and then subsequently you give what you call the vaccine. Okay. If rubella vaccine is administered subcuts or in the postpartum, remember, if one is pregnant, the person cannot receive rubella vaccine. That is what you need to understand. And the English will ask you via a subcut route, and then you need to inquire about sensitivity to egg. So people who are sensitive to egg when they take what we call the vaccine, there's a likelihood of them experiencing what we call allergic reactions and then hypersensitivity reactions. So we need to inquire about what we call whether the person is allergic to what we call egg before we give our vaccine. Then rubella vaccine is not given during pregnancy because it is life attenuated and then it can cross the placenta and then poses risks to what we call the developing fetus and can cause some form of congenital abnormalities. And so that is what I want. So the take-home message on here is that rogam and then rubella vaccine is not given together at the same time. You will need to give rogam first before you subsequently give what you call your rubella vaccine. Then rubella 2 is not given. Rubella vaccine is not given to a pregnant woman. If a pregnant woman, status is negative, the only thing you can do is probably to advise the woman to do everything possible to avoid contracting the viral infection. Then you wait for the person to deliver. And then after delivery, that is when you give the vaccine. After giving the vaccine, we tell them not to get pregnant for at least 3 months or between 1 to 3 months after taking the vaccine. They shouldn't get pregnant. That is what we need to understand regarding rogam and its schedule. Rubella titer status and then the vaccine for it. Any question on this? Any inputs here? Okay. Now let's quickly do glucose challenge test during pregnancy. The significance of glucose challenge test and why it is done. Okay. So glucose challenge test helps to screen pregnant women for gestational diabetes. I don't know whether, I think Akimili some time ago did endocrine with you. And then endocrine diabetes mellitus is one of the major conditions that when you are going for the NCLEX, you need to have it on your fingertips. So we have different types. One of the type is gestational diabetes. That is elevated glucose level during pregnancy. Largely because of hormonal changes. So the hormonal changes sometimes causes intolerance to what you call insulin ineffectiveness and then intolerance. And so it can lead to what you call the person having elevated glucose level. Okay. And when someone is pregnant and then the person has diabetes or there's elevated glucose level during pregnancy, the complication or the possible effect is on the fetus or is on the baby. At the end of the day, the fetus is going to receive a lot of glucose from the mother. And so that could lead to what we call macrosomia or the baby, gaining excess weight. Okay. Then another thing also is that when the baby is then born, the baby becomes at risk of what we call hypoglycemia. Why would the baby develop hypoglycemia if the mother was having elevated glucose level during pregnancy? You remember that the baby depends on the mother during pregnancy. And so the baby was receiving excess glucose from the mother. And the baby's, the fetus body was made to adjust to that by producing enough glucose more glucose, adequate insulin. The baby's body or the fetus body was made to produce, that is the liver, was made to produce the pancreas. The pancreas was made to produce more insulin, right? So that it will metabolize the excess glucose it is getting from the mother. Then when the baby is then born, because the body is used to excess glucose and then more insulin was being produced, when the baby is born, the insulin will keep on being produced. And so the body is producing more insulin. But the breast milk is also producing, should I say, little amount, should I say, it's not little, but then the glucose that the baby will be getting from the breast milk will not be that much for what we call the insulin that is being produced. So at the end of the day, there will be, this proportion between the amount of insulin the baby or the infant's body is producing as compared to the amount of glucose that the baby is getting from the breast milk. And so at the end of the day, if the insulin is too much and then it's too much, the baby becomes at risk of what? Hypoglycemia. That is why during pregnancy, healthcare providers would want to screen mothers to be sure whether the mother is at risk of what you call gestational diabetes. Okay. And if the mother is having gestational diabetes, we then manage what you call that to prevent all the things that I made mention of, macrosomia, and then possible hypoglycemia after delivery. That is fetal hypoglycemia or neonatal fetal hypoglycemia after birth. Okay. Then let's then look at how the screening is done. That is one of the important things. And so the screening is done by checking the glucose level of the mother during what you call the initial prenatal visit. But remember that gestational diabetes is diagnosed between 24 to 28 weeks of gestation. So gestational diabetes is actually diagnosed and confirmed between this week of duration. So between 24 to 28 weeks, that is where we confirm what we call gestational diabetes. And so let's say that the woman comes at 12 weeks, that is the first visit, and then we do our initial, let's say, random blood sugar, and then the value is elevated. Now, we will only caution the mother and advise the mother to return back at 24 to 28 weeks for a confirmatory test to be done. So, screening of gestational diabetes begins at the initial prenatal visit and is diagnosed by either using the fasting blood glucose. We are using milligram per deciliter. That is the standard for the NCLEX in the US. Okay, and so we are using milligram per deciliter, but you see the millimole per liter value also attached. And so when we do our fasting blood sugar, and then the fasting comes out to be, let's say, above 126, that is above 7.0 millimole per liter. Or when we do glycated, I hope you know glycated, that is glycated hemoglobin, amount of glucose that is attached to the red blood cell, which is carried through the body. And we know that the ideal lifetime for what we call red blood cell is between 90 to 120 days. That is about 3 months. Okay. And so red blood cell will die after 3 months or after 90 to 120 days. And so glycated hemoglobin talks about the glucose that get attached to the red blood cell for it to be circulated in the blood for a period of 90 to 120 days. And so we say that glycated hemoglobin helps you to determine how well one's blood sugar level is controlled for a period of 90 to 120 days. And so in some books, they will say that glycated hemoglobin is the perfect method, or is a perfect method to screen a client or to determine how well one's glucose level is controlled. And glycated hemoglobin, that is HbA1c, is rated in percentage form, right? And so anything more than 6.5, it's a red flag. So when you go and do HbA1c and you are getting more than 6.5, it is a red flag. It indicates that your body is not metabolizing glucose well. Okay. And so if glycated is more than 6.5, we note that kind of women. Or when when fasting is above 126, we also note it down. So we can use either of them. Either we are using fasting, or we are using glycated, or we are using random. So the random two, we look at anything that is more than 200. That is 11.1 millimole per liter. So if a woman comes, we will determine which of them. So we know fasting, you need to fast before we can do that. So let's say the woman comes, likely we are going to do random. So if we do the random for that woman for the initial visit, and the random is more than 200, it's a red flag for that woman. So that woman is told to come back at 24 to what you call 28 weeks for the confirmatory test to be done. So the confirmatory test, we use what we call the glucose challenge test. Okay, I hope you have heard of glucose challenge test. We use glucose challenge test as our confirmatory test for glycated, for diagnosing pregnancy-induced diabetes or gestational diabetes. And so the glucose challenge test comes in two forms. The first one is that we'll do what we call a 1-hour glucose challenge test. And so the 1-hour glucose challenge test, it can be done at any time of the day. I take that again. The 1-hour glucose challenge test can be done at any time of the day, regardless of the time. You can do your one hour glucose challenge test. So what we do is that I've already said that before one will be asked to do the glucose challenge test, the person random sugar might have been elevated, okay, for her first visit, and she was made to come back again between 24 to 28 weeks for the confirmatory test, which is the glucose challenge test to be done. So the glucose challenge test is actually a confirmatory test. So what we do is that we give the pregnant woman 50 grams of glucose load. Okay, we give the woman 50 grams of glucose load. Then we ask the woman to wait. Okay, you ask the woman to wait for 1 hour. That is why we say 1 hour glucose challenge test. After 1 hour, the glucose should be metabolized. And then after the glucose is metabolized, after the 1 hour, we then pick the blood sample, and then we test the sugar level. And so if we test the sugar level after the 1 hour glucose challenge test, and the glucose level is greater than 140, that is 7.8 millimole per liter, we say that the person has failed the 1 hour glucose challenge test. And so the person is subsequently made to do a 3-hour glucose challenge test, which will finally conclude that the person is having gestational diabetes. And so if for the first visit, your glucose level was normal, for instance, we did a random for you, and your random was less than 200 milligram per deciliter, you wouldn't need to do glucose challenge test. Glucose challenge test will only be done if your glucose level was elevated, that is above what you call 200 milligram per deciliter for your initial visit. That is when you do come back at 24 to 28 for the glucose challenge test. So I said glucose challenge test, the first one we do is 1 hour. So the 1 hour, the person will come at any time of the day. We give them the glucose load, that is about 50 grams. Then they are asked to wait for 1 hour. After 1 hour, we take their blood, we test for what we call the glucose level. And so if after the 1 hour, the glucose level is more than 140, that is 7.8 millimole per liter, it means that the person has failed the 1 hour challenge test. We call it a failed challenge test. So you are then booked to continue with what you call the 3 hours. And so the 3-hour glucose challenge test is only done for people who have failed the 1 hour. That is, if after the 1 hour, your glucose level was more than 140 milligram per deciliter, you are asked to do 3 hours. And so the 3-hour glucose challenge test, for that one, it has a specific time that has to be done. So that one, we do it with time. Okay. And so the person will be made to fast for at least 8 hours for a 3-hour glucose challenge test. For a 3-hour glucose challenge test, the person will be made to fast for at least 8 hours. And then after 8 hours, the person is given about 100 grams of glucose load. And then the person is asked to wait for 3 hours. And so after 3 hours, we test the blood again. So when we test your sugar and your sugar is more than that is 130 to 140, it's then conclude that you are having what we call gestational diabetes. And so for gestational diabetes, we don't just use one thing or one test to confirm. The person has to go through 3 tests for the person to be confirmed as having what we call gestational diabetes. So the first one is the first visit we do when the glucose level is more than 200 for a random. You are asked to come back at 24, between 24 and 28. You come back, we do 1 hour. If the 1 hour is done and then your glucose level is more than 140, you are made to continue with what you call the 3 hours. So the 3-hour glucose challenge test, we said that one, you do it with time. You need to let the person to fast for at least 8 hours. But 1-hour challenge test, no fasting. It can be done any time of the day. You can do 1-hour glucose challenge test. It is 3-hour glucose challenge test that you need the woman to fast for at least 3 hours. So in your question, you can get a question and say, and then the question goes by. A woman is scheduled for a 3-hour glucose challenge test. Which statement from the woman requires a follow-up? And the woman make a statement that the 3-hour glucose, I know that 3-hour glucose challenge test can be done any time of the day, regardless of time. 2, I will need to fast for at least 8 hours for my 3-hour glucose or before my 3-hour glucose challenge test. Then 3, after taking the glucose load, I would have to wait for, I know that after taking the glucose load, I would have to wait for 3 hours. Then they give you something else. Which of them will you, be made to educate the client more on? You have to understand that if your client say that the glucose challenge test can be done any time of the day without me fasting, that is a wrong statement. Client doesn't understand, because we said that for a 3-hour glucose challenge test, client will need to fast for at least 8 hours. And so mostly it's done early in the morning because client slept overnight. And so during the night, client did not take anything. And so in the morning, client might have fasted enough. And so you can do your 3-hour glucose challenge test during that time. Okay. Any question on what we call how to do your glucose challenge test to diagnose for gestational diabetes? If you have any question, you can bring it
Yeah,
up.
I have a question.
Yeah. Okay.
When I was pregnant with my second child, I was told to do this same test. I did the first one, second, and I did it. I did even more than 3 times. So the third one, the one I did, they said I should fast. I shouldn't eat once it's fixed. I shouldn't eat the next day. So now I'm just hearing that you're saying 8 hours. Just 8 hours. If they told me not to eat by 6, I guess the 8
I
hours, it
said
was more than 8 hours.
I said at least 8 hours. I gave a time. I said at least 8 hours. And so it could be more than 8 hours. It is, I mean, I am not specific that the 8 hours is what you need to fast, but I said at least means that you are not going to be made to fast not less than 8 hours. So it can be 8, it can be depending on the healthcare provider and where you are doing your test. That's why I give at least. I don't know
Okay.
if that is that makes sense, because I said at least. So at least means that it could be 8 hours or more, but it will not be
Okay.
anything less than 8 hours. So depending on where you are going to do and then what they will tell you. But remember, you are not going to do it. The fasting will not be less than 8 hours. That's what I want you to understand.
Flamingo.
Yes, madam.
Praise the Lord.
Mhm.
So please, with the 50 gram of glucose that they give, is it
Mhm.
IV or oral?
Or
I just
oral.
want to know.
It's over the
It's
oral glucose. It's on my
oh, okay,
screen.
okay,
The oral is
okay,
there. So
okay.
it's oral.
I'm listening. I'm not looking on the screen. I'm
Okay.
just
Okay.
listening.
All right. All right.
Thank you.
Okay. All right. Let's see. Any other inputs here? Any other inputs? Means that everyone is fine. Any other question here? So you see, someone says she has experience. She was made to do all these things when she was pregnant. So if you are pregnant, let them test you. Okay. Let them do the test for you to. Of course, if you are pregnant for your first visit, you do either random or fasting. So they will be able to be sure whether you are at risk or not. Okay. Any question, any addition, any input here? Today I'm talking a lot. I have my questions there. We'll get to questions. But I don't know whether I can finish what I have to do before we do our questions. So let's continue if there's no more question. We talk about amniocentesis and why we do amniocentesis. And then after amniocentesis, what we need to know. Okay. And what we need to educate our clients on. So amniocentesis is done where it's done to obtain amniotic fluid for investigation to assess for any form of congenital abnormalities, right? And so it is done by aspirating what we call amniotic fluid, where a needle will be inserted into the abdomen and then the fluid is obtained, mostly performed between 15 to 20 weeks of gestation, because that is where you tend to have most of the cells being viable. And so, and then adequate amniotic fluid is also at around that week of gestation. So the test is mostly, or the procedure is mostly performed during that week of duration or that week of gestation. The purpose of doing amniocentesis is to, one, obtain amniotic fluid to screen for any form of genetic disorders, any form of metabolic defects, as well as to assess for fetal lung maturity as well. In the NCLEX, what they want you to understand is client preparation for amniocentesis. And then after amniocentesis, what are the things that you have to educate the clients on? Especially infection. So infection is one of the things that you always have to educate the client that after amniocentesis, they will have to monitor for what we call infection. And so after amniocentesis, if they notice any form of temperature changes or temperature rising, they would have to inform the healthcare provider as early as possible. And then they would have to also monitor the size of the incision for any form of bleeding or abnormal fluid loss from the incision side. Remember, I also made mention that amniocentesis is one of the things that when you do it and there is a puncturing, you puncture, let's say, an organ, or you puncture the placenta or whatever, you don't do it well and cause any form of injury, and the mother is having a rhesus negative to a rhesus factor negative, you will consider giving what we call ROGA, right? So it is an invasive procedure, and because it's an invasive procedure, you would have to consider what you call your consent form before the procedure. So ensure that um informed consent was obtained by the healthcare provider. I've already established the fact that this procedure is done between 15 to 20 weeks of gestation. And then when the thing is done, when amniocentesis is done less than 20 weeks, the woman will be made to have a full bladder before what you call the procedure. So it can support what you call the uterus. And then if it is after 20 weeks of gestation, we tell the mother to empty the bladder. Okay, because if the bladder is full after 20 weeks of gestation and the amniocentesis is to be done, there is a likelihood of the bladder being punctured after 20 weeks. And so we have to understand client education and the time they are doing. And so if you have a question which says that a mother is scheduled for amniocentesis at 18 weeks of gestation, what will be your client's education? What are the expected client education? One, encourage the client to empty the bladder. Two, encourage the mother to have a full bladder. And then they have other things. And you get this and you are confused. Remember one of the things that when you are answering an NCLEX question, we always say that two opposite answers, when you get two opposite options in one question, the likelihood that one of them is correct is high. And so if the mother is less than, or if the pregnancy is less than 20 weeks and the woman is going in for amniocentesis, we say they should have a full bladder. And so not the one where they have to empty the bladder. But if it is after 20 weeks, and they are going in for amniocentesis, in order to prevent the bladder from being punctured, we encourage them to have what we call an empty bladder. That is one thing. Then they will need to do an ultrasound so that they will know where to perform what you call the procedure to locate the placenta so that they wouldn't cause any form of unnecessary injury or puncturing. Vital signs very important. So you know the fetal heart rates, you know the maternal blood pressures and then everything. So that after the procedure, you can monitor, kindly mute up, man, so that after the procedure, you can monitor to see whether there's any form of complication developing. Then we encourage the client to remain supine, okay, during the procedure, and then on the left side after the procedure. So mostly during the procedure, the mother would have to lie on supine. Then the incision is made or the insertion is made. Then after the procedure, the mother would be made to lie on the left side. Those are things that we need to understand. Amniocentesis can cause certain complications or can lead to some form of risk to the mother. And so I've already talked about rhesus isoimmunization, where if the mother is having a negative rhesus factor and the mother goes in for amniocentesis and there is any form of injury, the mother will need to take what they call the ROGAM. So you have to understand that it's one of the things you need to consider when you are to perform ROGAM. There's possibility of what you call hemorrhage that can occur, or yes, if the needle is inserted, they cause some form of puncturing in some organs, and that could lead to injury and bleeding. Miscarriage can happen. Fetal injury can also happen. Infection, which is one of the things that the NCLEX usually asks, which is associated with the incision of the needle. And so if the procedure, we know this procedure has to be done under aseptic technique. So if there is any form of compromise in terms of during the procedure and then infection setting, it's something that we need to consider. There can also be issue mute. Madam Hamdia, mute her for us, okay? Kindly mute her for us, Madam Hamdia. We can also have abruption happening. You can have amniotic fluid embolism all developing, okay? And then premature separation of the premature rupture of the membrane can also happen, which can all lead to infection. And then preterm birth can all happen after that. So after amniocentesis, instruct the client that it is necessary to notify the healthcare provider if they experience chills, temperature that is greater than 100.4 Fahrenheit, that is 38 degrees Celsius, and then bleeding, any form of unusual bleeding, any form of unusual passage of clots or tissue, and then any form of leakage of fluid at the needle incision site, they will need to report that. Or when they notice that fetal activity has decreased. So decreased fetal movement and then uterine contraction or cramping. So if after amniocentesis, the mother is complaining of any of these things, you will need to report, or the mother will be made to report to the healthcare provider for further evaluation. Okay, it could be that it is complication that has developed. Any question on this and its complication? If you have any question, you can bring it up before I talk about stress test, that is non-stress test. All right, so let's look at non-stress test and its importance when it comes to pregnancy. So non-stress test is done to ascertain if the mother can undergo normal spontaneous vaginal delivery and then the baby can also tolerate the stress of what you call labor. Okay, and then to also assess to see or to evaluate fetal well-being and then how the placenta is also supplying oxygen. Okay, so it is performed to assess placenta function and oxygenation. The test determines fetal well-being and to evaluate fetal heart rate in response to fetal activity. Okay, so we are looking at what happens to the fetal heart rate during fetal activity. So this is non-stress. The reason why it is non-stress is that the fetus will not be allowed to undergo any stress. It is just the normal fetal movement, fetal activity that we are going to monitor in response to fetal heart rate. So when we talk about stress test, you understand that under contraction stress test, you are going to cause the fetus to undergo a certain form of stress. Okay, but under non-stress test, no stress, the fetus is not made to undergo any stress. That is why it says non-stress test. So first, I've already established why we do non-stress test: to evaluate fetal well-being, to evaluate oxygenation of placenta function, and then oxygenation, how it supplies oxygen to the fetus, and then fetal heart rate in response to what we call fetal movement. Under normal circumstance, whenever there's fetal activity, we want to see that fetal heart rate also goes up. So it's just like when you walk or when you run as an adult, when you run, what happens to your heart rate? Your heart rate goes up. And so the same thing for a normal fetus or a fetus without any form of issue. When there is any form of fetal movement or after fetal movement, the fetal heart rate has to go up. Okay, the fetal heart rate has to go up. If there is, there is a fetal movement, and then after the fetal movement, there is no increase in fetal heart rate, or the fetal heart rate remains the same after fetal movement, then there is something wrong with that fetus. Okay, so fetal heart rate is assessed in response to fetal movement. Let's look at what goes into the procedure. So first of all, you must have your monitor around. So there's an external monitor that you are going to use to monitor what you call the fetal heart rate. That is what you have to understand. Then the monitors are applied to what you call the abdomen or the mother's abdomen. The mother is given what we call a button on the monitor that the mother has to press. Anytime the mother experiences fetal movement, the mother should press what you call the button on the monitor, and the monitor will record the fetal activity. Okay, so that thing is done for a period of 20 minutes. Okay, the mother is made to undergo that procedure for 20 minutes. Monitors are applied. The mother is given a button on the monitor to press anytime the mother feels fetal movement. And so after 20 minutes, the healthcare provider will come to then read what is on the monitor or to assess the fetal heart rate in response to the fetal activity. Remember, I said that during every fetal movement, the mother presses on the button, and then that activity is recorded on the monitor. And so after the 20 minutes, the healthcare provider comes to pull, the record or whatever is on the monitor, and then will assess it with what you call the fetal heart rate. Okay. And then urethral activity will also be monitored. We have to monitor the maternal blood pressure along the line, and then we monitor the mother as well. The position for the procedure is that the mother will be made to lie on the left lateral position, because we said we don't want to cause any form of syncope or hypotension that could lead to a drop in the maternal blood pressure. So we put the mother on the left lateral during the procedure. And so after the 20 minutes, we go to pull the monitor and look on the monitor what happened to the fetal heart rate during the fetal activity. And so I said that under normal circumstance, after every fetal movement or during every fetal movement, the fetal heart rate has to increase. And then after the fetal activity, the fetal heart rate will drop back to the normal or where it was before the increment. Okay, so the client may be asked to press a button every time the client feels fetal movement. The monitor records a mark at each point of fetal movement, which is used as a reference point to assess the fetal heart rate response. Okay, this is the procedure. Let's look at the outcome. What the NCLEX want us to know regarding non-stress test. So the outcome is two. It is either there is increase in fetal heart rate in response to fetal activity during the procedure, or the fetal heart rate remains the same, okay, during what we call the procedure. And so the first resource is, we term that as normal or negative or reactive non-stress test. So reactive non-stress test, wherever you see that, is a normal non-stress test, and it is negative. Negative means that there is no problem with the fetus. The fetus is doing well. I take that again. A reactive non-stress test is a normal response or a normal non-stress test, which is a negative. Negative means that it's normal, everything is fine. So reactive indicates a healthy fetus. Now, what does a healthy fetus mean? A healthy fetus means that during every fetal movement, at least there is an increase in fetal heart rate, or the result requires that there is 2 or more fetal heart rate acceleration. When I use acceleration means that an increase in fetal heart rate. And so there is an increase in fetal heart rate of at least 15 beats per minute, lasting for at least 15 seconds from the beginning of the acceleration to the end during what you call during fetal movement for that 20 minutes period. So what I am saying is that during fetal activity, we expect fetal heart rate to go up. So let's assume that the baseline fetal heart rate is, let's say, 120. Okay, that is the baseline fetal heart rate before the procedure. This is the baseline. Then we are saying that during non-stress test, for us to get a normal non-stress test or a reactive non-stress test, we want to see an acceleration, that is an increase in the fetal heart rate to at least 15 beats per minute, lasting for at least 15 seconds before it returns back to the baseline. So let's use the 15 beats per minute. So baseline is 120. During fetal movement, we want to see at least the fetal heart rate increasing to 135 during fetal movement. Then after the fetal movement, the fetal heart rate will then drop back to the baseline. At least during the 20 minute duration you are doing the procedure, you have to see at least 2 of these things happening. So at least there have to be at least 2 or more fetal heart rate acceleration of at least 15 beats per minute lasting for 15 seconds. And that indicates that the fetus is doing well. The fetus is getting adequate oxygenation from the placenta. And then the fetus can also tolerate the stress of what we call labor during delivery. So when this happens, you don't do any other thing again. It means that the fetus is fine. And then, like I said, it can undergo normal spontaneous vaginal delivery. However, if you do your test or you do your monitoring and after 20 minutes, there hasn't been any form of increment or there hasn't been any form of acceleration in the fetal heart rate, what you do is that you continue your monitoring for another 20 minutes for a period of 40 minutes. And so after the 40 minutes, we come to then assess. And so when you do your assessment and then you notice that there was no movement, or even when the movement happened, there was no acceleration or the acceleration was not up to 15 beats per minute, we say that the woman had failed the non-stress test. So a failed non-stress test is that no acceleration or acceleration of less than 15 beats per minute lasting for 15 seconds in duration during a 40-minute observation. So you did your monitoring, and then after 40 minutes, whenever there is fetal movement, you don't see an increase in the fetal heart rate of at least 15 beats per minute, or the fetal heart rate remains the same throughout the 40-minute duration. What we say is that the woman had failed the test, and that means that there's something wrong with the fetus. Either the fetus is not getting adequate oxygenation or fetal activity is not adequate. Okay, so there's something wrong with the fetus, and the fetus might not be able to tolerate the stress of what you call labor. That is a stress of normal spontaneous vaginal delivery. And so for that, the woman would be made to undergo something we call contraction stress test, which is, another test that you do so that you then conclude whether you have to do cesarean section or the woman can go through the spontaneous vaginal delivery. So if after the test, after 20 minutes, there was an acceleration, that is fine. It is normal. The woman is allowed to go. But if after 20 minutes, we realize that no acceleration, we continue the monitoring for another 20 minutes to get 40 minutes. And so if after 40 minutes, the thing is still the same, no acceleration, or there is no increase in fetal heart rate during fetal movement, we say that it is a non-reactive, non-stress test or a failed non-stress test. And that is a cause for concern. So in that regard, you have to report that to the healthcare provider. And the healthcare provider would then require that the woman undergo what we call a contraction stress test. So with the contraction stress test, the woman will be given what we call medication, and the medication will mimic what we call contraction labor, or will mimic or will cause the woman to feel as if, or the fetus to feel as if labor is occurring. And so that will be the conclusive. But before I talk about contraction stress test, if you have any question on non-stress test you want to ask, kindly ask your question before I move to what you call contraction stress test.
Sir,
Yes.
yeah.
Yes.
I remember, can you give glucose to the mother if you do the first 20 minutes, or toffees, or a chilled drink? If you do the first 20 minutes and then you realize that the there is no reaction.
There's no increase.
Yes. Yeah, because I remember when I was pregnant, they did the stress test, but for the first, I think, was it, I can't remember the minutes, or but they gave me toffees, and then they asked if I have drink, and I like they wanted to give me drink, and I said, oh, I have a drink, and then I took it. Then they did it again before they left, but I didn't even ask of the whatever. Can that be done? Hello, hello, please, can you hear me? Hello, Zamingo. Hello.
Hello, I got your question.
Oh, thank you.
Yes, I got your question, and I was addressing it. No, when I've muted myself. So what I was saying was that, during non-stress tests, after the 20 minutes, it's a monitoring we are doing. Probably, maybe why they gave you that the drink was that probably they suspected maybe the fetus was asleep. And so they are giving you something that
He said I should tell my baby to wake up.
is that?
He said I should tell my baby to wake up. Since my baby is
Uh-huh.
asleep.
Yes, so probably that is why they gave you the toffee to, or they were asking whether you have toffee to take it or you have water. Because when the fetus is asleep, there wouldn't be any form of fetal activity where you be able to pick what we call the acceleration in fetal heart rate. So maybe that was why they gave you. But for the purpose of what we are doing today, taking a drink or something like that wouldn't have any influence on non-stress test. Okay. So after the 20 minutes, if there was nothing seen, you continue that for another 20 minutes. Okay. Maybe if during the first 20 minutes, if the child was asleep, we say that for a fetus to be asleep, it will not be more than 30 minutes. And so after 30 minutes, if the fetus is still not active, then there is something wrong with the fetus. That is why you will continue the monitoring for an additional 20 minutes. So that if after 30 minutes, because the maximum number that if you want to monitor for fetal activity for at least 30 minutes. If the fetus is not active after 30 minutes, you will feel the fetal movement or there will be fetal activity. All right. Any other question before I do contraction stress test and leave it here? I wanted to finish this so that next week when I come, I can do something else. So contraction stress test, that will be the last thing we are doing, then we drop it here. It's done when a woman fails a non-stress test. So after a non-stress test, if the test comes out, after a non-stress test, if the test is non-reactive, okay, if the test is non-reactive, meaning that after the process or after the procedure, there was no acceleration, okay, in the fetal heart rate, the woman will be made to undergo contraction stress test. So contraction stress test also same thing, assesses placenta oxygenation and then function. The test determines the fetal ability to tolerate labor and then determines fetal well-being. The fetus is exposed to the stress of contraction to assess for, adequate placenta perfusion. And so labor is kind of stimulated. So when labor is stimulated, you then assess to see how the fetus is, behaving. Okay, so here the test is performed if it is believed that the fetus needs to be delivered and that the fetal ability to tolerate labor is unclear due to a failed non-stress test. So that's why I said that if the fetus fail a non-stress test, we do contraction stress test. And the contraction stress test requires that we stimulate labor, okay, artificially stimulate labor. I hope you are getting me. So we artificially stimulate labor to see how the fetus will behave during that period of stimulated labor. What goes on is that same thing, you put your monitors on the mother. The procedure is done for a period of 20 to 30 minutes, okay? And then the uterus is stimulated, okay, to contract by administering what we call diluted dose of oxytocin. We know oxytocin is used to augment labor, right? It's used to stimulate labor. So because we don't want labor to go on, or we don't want the mother to deliver, so it will lead to, let's say, premature labor, even with contraction stress test, because we are stimulating labor, it is mostly done when the mother is at term gestation, because you can't do this if the person is not at term. If you do it and the person goes into labor automatically and then the person was less than 37, it means that you are going to have a preterm labor or a preterm birth. So we usually do this when the mother is at term gestation, so that even if we stimulate the labor and the person delivers, there will not be any cause for concern, okay? So, but then the dose of what we call the oxytocin will give is usually a diluted dose, which will not cause any problem, right? Then, or we can also have the client nipple stimulated. So by having the client use nipple stimulation until 3 palpable contractions with a duration of 40 seconds or more in a 10-minute period have been achieved. So we use two things to stimulate the labor. Either we are giving a diluted dose of oxytocin or we are stimulating the nipple. We are using a nipple stimulation method to stimulate what you call the contraction. You know that when you stimulate the nipple, oxytocin is also produced, and that is natural oxytocin, and that can cause the uterus to contract. Okay, so this is done to assess, like I said, how the fetus will behave, or to assess how the fetus will behave if the fetus is undergoing normal spontaneous vaginal delivery. We monitor maternal blood pressure And then we also monitor the fetal heart rate as well during the procedure. So this also comes out to either be a negative or positive. So a negative contraction stress test is normal. So when you do your contraction stress test, we are looking at a normal and an abnormal result. An abnormal result is also termed as a negative contraction stress test, which is that it indicates that there was no deceleration. Deceleration in fetal heart rate means that a drop in fetal heart rate during contraction. And so when you stimulated contraction, did you see on the monitor whether there was any drop in fetal heart rate? So if you notice that there was a drop in fetal heart rate during contraction, it means that that fetus cannot tolerate labor or cannot tolerate the stress of what you call normal spontaneous vaginal delivery. Because if the fetal heart rate is dropping during contraction, it is not expected. It is not something normal. So a negative contraction stress test, which is normal, indicate that a negative result, which is represented by no late deceleration of the fetal heart rate. So no late deceleration means that there was no drop in fetal heart rate during contraction. Then we have a positive contraction stress test, which is the abnormal one. So abnormal is the same as a positive contraction stress test, which is that during contractions, there was a drop in fetal heart rate of at least 50%. Okay, so it says that a positive result is represented by a late deceleration of fetal heart rate with 50% or more of the contraction in the absence of hyperstimulation of the uterus. So what this is saying is that when we stimulated the uterus, of course, we will monitor the fetal heart rate. And so when you monitor the fetal heart rate and you realize that during the fetal heart rate monitoring and during contraction, there was a drop in the fetal heart rate, then that should tell you that that fetus cannot tolerate what you call contraction, cannot tolerate normal spontaneous vaginal delivery. And so for such a fetus, the woman will need to undergo cesarean section for the baby to be taken out. If not, if you try to allow the woman to go through normal spontaneous vaginal delivery, you are going to have complication developing at the end of the day. And so that is on contraction stresses. So remember, contraction stress test is done after what you call non-stress test. If the woman failed a non-stress test, you do contraction stress test. And then contraction stress test, also you are looking for a normal and abnormal. A normal is that during contractions or during the stimulated contractions, there was no late deceleration. And then that is a drop in the fetal heart rate that happened during contractions. Then positive contractions, positive contraction stress test, which is an abnormal and we don't want, is that during the contractions, which was done after we give what we call the diluted oxytocin, there was what we call a drop in the fetal heart rate alongside the contraction. So when that happens, you would have to report to the healthcare provider. And so for that woman to undergo normal spontaneous vaginal delivery. That is on contraction stress test, and then it's relevant. Any question on all that I have said today? If you have any question, any inputs you want to make, kindly bring it up. Hello. Are they there or they've run away?
Please, we are here.
We are here.
Okay, they are there. All right. Any question before I drop it here? I've spoken a lot, eh? All right. So I know that I've taken your time. And so because of that, I will just leave it here. God willing, tomorrow. Sorry, not tomorrow, we are not meeting. So next week when we meet, we'll start with questions on all that I spoke on so that we'll pick it up from there. Any inputs, any clarification, any addition. I know I've spoken a lot. When you get the recording, you can listen again and then you have a better understanding on all that I spoke about. Any question, any addition, any input here? Yes, Madam Vivian.